Hello everyone. Today my topic of discussion is Vbac, that is vaginal birth after cesarean. So, coming to the part of introduction, the increasing rates of primary cesarean section have led to an increase in the proportion of obstetric population with the woman with the history of uterine scar. So, management of pregnant women with prior section is a controversial topic regarding mode of delivery due to the fear of the uterine rupture. So, Kragen in 1916 had given dictum that once a caesarean is always caesarean, as those days caesarean deliveries were performed by the classical upper segment route. So we know that there are different types of uterine incisions. Taking this as a uterus, the classical upper segment route is the incision given in the upper segment, and the incisions which we are nowadays doing is the lower segment incisions. We will discuss in detail regarding these incisions. Most cesarean sections are now done by the lower segment transverse incision, which has very lower rate of rupture. So hence the trial of cesarean, that is Tolac, and Vbac, that is vaginal birth after cesarean, are feasible and safe with the availability of effective antibiotics, safer anesthesia, and also with the facilities for the blood transfusion. Hence, the dictum has now changed to once a caesarean is always by hospital delivery. This is more appropriate for nowadays. So, pregnant women who had previous cesarean delivery can deliver in one of the following ways, which include trial of labor after a previous cesarean, that is a Tolac, ending in the Vbac. So, the difference between, we need to observe one thing here, that there is a difference between the terms Tolac and Vbac. So, Tolac is just a trial. When it becomes successful, it is called as Vbac. So, this is the first option where the trial has become successful, ending up in Tolac leading to Vbac. Next, second thing is a failure of Tolac. That is, we have given the trial of labor after previous cesarean delivery. This has ended up in the emergency section. This is called as failed Tolac. This is second type. And the third way is a planned or elective repeat delivery. In these women, in this category, there is no trial for Tolac. We are directly going for the elective repeat section in the woman who has a previous section. So, attempting a vaginal birth after a single previous LSCS is safe and appropriate, but that should be offered to the selected women who fulfill the criteria for the possibility of successful Vbac. So, for this reason, for selecting the women who are likely to undergo Tolac, we need to know the further details and what are the criteria which are to be fulfilled by the women. So, women with one or more previous vaginal birth. For example, a woman has undergone an SVD followed by an LSCS. So, in this woman, now we can try for a Vbac. The chances of her successful Vbac are more, as she has a history of previous SVD. So, particularly one or more previous SVDs, particularly previous Vbac. If this is one case, and if at all the woman has a history of LSCS first, followed by a successful Vbac, this woman can now also undergo a Vbac. This woman has also more chances than this first category, because she has a previous history of successful Vbac also. So, the planned Vbac is success in 85 to 90%. All these percentages are important to counsel the female when they come to us in the OPD. So, advantages of achieving Vbac. What are the advantages? The main advantage is we are going to avoid a major abdominal surgery. So that we are preventing all the complications associated with the abdominal surgery. That is, it has now the risk of hemorrhage has become reduced, and the infections and the injuries, okay, all the things will get reduced, and it has a shorter recovery period. So, in women planning for further pregnancies, for example, there are few females who are also planning for next pregnancy. So, if she has LSCS first, if she undergoes Vbac now, the next pregnancy, the chances of vaginal deliveries will be more. So, we have to counsel her in that way. If the women are planning for further pregnancies, Vbac is a good option for them. As a if she undergoes a section, she becomes a two previous LSCS. This can be a high risk pregnancy. So VBAC avoids potential maternal consequences of multiple cesarean deliveries, such as bowel and bladder injury, hysterectomy, blood transfusions, infections, and abnormal placentations like placenta previa and placenta accreta. All these complications of a cesarean section can be avoided with the successful VBAC. So what are the risks associated with the TOLAC? So coming to the incidents, the major first important thing is the uterine rupture. Every obstetrician, the worry of every obstetrician for the woman undergoing TOLAC is this uterine rupture. Its incidence is only for 0.5 to 1%. So we need to counsel the woman when we are advising TOLAC in such a way that this happens only in 1 in 100 women. It's not that everyone is who are giving trial may end up in uterine rupture. So we have to assure them that the risk is very minimal. So this is one of the severe adverse outcome, and when the uterine rupture occurs, there is a significant risk of obviously if the rupture has happened, then there is a risk of bladder injury, transfusion, and also infections. But and all this, if at all this has rupture has occurred, then approximately 25% of the female who had rupture may end up in the hysterectomy also. This should be also included while counseling the patient. So compared with the successful TOLAC, the risk of these major complications was fivefold in women who have failed TOLAC. We have seen that there are three possibilities. The second possibility is failed TOLAC, right? In such women, the rupture rates are even more higher. Not rupture rates, all the associated LSCS complications are much more in the failed TOLAC. So what in the failed TOLAC, overall composite morbidity having VBAC is 2.4. In women who underwent emergency LSCS is 14.1%. So if she has successful VBAC, then the composite morbidity is only 2.4. But if he has failed TOLAC, then the complication rate becomes much higher. So this is a one factor of concern. Coming to the fetal and neonatal risks, the risk ratio of neonatal death and neonatal morbidity and mortality are higher in women who has attempted TOLAC. That is second category of failed TOLAC. They also have the risk of infant developing the hypoxic ischemic encephalopathy. So the if TOLAC, if we are offering TOLAC, the perinatal morbidity rates are increased. If that was an elective section, it is only 0.05%, but the risk has increased it to 0.13% when it comes to the neonatal point of view. So the absolute risk, this point is in favor of TOLAC again. Transient tachypnea of a newborn are slightly higher This transient tachypnea of newborn is higher in the elective repeat cesarean delivery cases compared to the TOLAC. So, but the overall 5-minute APGAR scores or neonatal intensive care admission rates, if we take into consideration, that didn't differ much from those women who have undergone elective section and who have undergone TOLAC. So the overall APGAR, 5 minutes APGAR and NICU doesn't differ much. So who are the ideal candidates for the TOLAC? The women who has singleton pregnancies and cephalic presentations and more than equal to 37 weeks of gestational age with previous LSCS and with or without previous SVDs. So these are the ideal candidates for the TOLAC. Okay, what are the absolute contraindications for TOLAC? If the woman has a history of uterine rupture or any history of scar dehiscence, and any history, if the history like previous incisions were classical T or J-shaped incisions, or any history of myomectomy, any 3 or more previous LSCS and placenta previa, and if any, obviously if there is any obstetric complications, and if the TOLAC is refused by the patient, then these are considered as the absolute contraindications. So, a successful VBAC has fewest complications, but failed TOLAC, which is ending up in emergency section, has greater much adverse effects. So, ideal in the ideal candidates, the one previous LSCS is included, and in contraindications, more than 3 previous LSCS is included. Then what about two previous LSCS? In two previous LSCS, we can go for the trial of Vbac, but it is not absolutely contraindicated. But the risk of rupture is much higher in two previous LSCS. We'll discuss it further again. So, coming to the type of incision. So, women with one previous LSCS has the lowest risk of a symptomatic scar separation. In women with if the incision was given in the lower uterine segment only, lower uterine segment only. If it is horizontal, it is transverse, the risk rate is different. If it is lower uterine segment, vertical incision, the risk rate is different again. So this can also be the candidate. These are the candidates for TOLAC, and this is also the candidates for TOLAC. In women who have undergone a classical cesarean section scar, previous history of classical cesarean scar, in these women, the rupture might also occur before the labor onset. That is, this may occur even before the term. So they are the very high risk group. In such cases, according to ACOG 2021, it recommends that delivery should be done 36 to 37 weeks itself, as they have the risk of rupture even before the term itself. So we need to go for the section early, plan for section early. Next, coming to the one more important thing here is the what are the incision types and what are the estimated rupture rates. So this is one important thing which should be remembered. This will be helpful to counsel the patients. So in women having one previous transverse cesarean sections, the risk rate is 0.2 to 0.9%. In the woman who has a multiple low transverse incision, and the risk has almost doubled. So 0.9 to 1.8%. If it is low vertical, this category, if it is low vertical, it is again 1 to 7%. We can try for the TOLAC, but the risk rate has been increased. The classical section is even more, 2 to 9%. If it is T-shaped, it is much more, 4 to 9%. And so the prior history of uterine rupture. And again, if the rupture is in lower segment, it is 2 to 6. But if it is in upper segment, then it is very, very much higher. So the history of rupture is an absolute contraindication for TOLAC. We have seen in the previous slide. So this is a comparison table here showing the lower segment scar and the classical upper segment scar. Why the classical caesarean scar has so many, why the risk rupture rate is higher in the classical caesarean scar will be understood in this slide. Coming to the suturing. If the scar is in the lower segment, the suturing will have better apposition, and because the neat and cut even margins will allow perfect apposition, so that there won't be any left out pockets. So without leaving any pockets, there will be a very good apposition. So this has better healing. In the classical scar, it has poor apposition because of the thick margins of the upper segment, and this has chances of blood pockets are formed. Blood pockets will be formed, and thus that will hinder the healing. I'm sorry. Healing in the perperium. It is better healing because the lower uterine segment is quiescent during the process of retraction, and the classical scar becomes healing is imperfect due to the contraction and retraction which happens in the upper segment. So and making the sutures loose with the imperfect healing. So classical section scar becomes sutures will become loose in the classical segment scar. And in the stretching in the future pregnancies, in the case of lower segment, this will occur along the scar. In the case of upper segment, this occurs at the right angles. So this will make the scar much weaker. The placental implantation in the subsequent pregnancies. This can happen coming to the lower segment. This can happen over the scar, but this won't weaken the scar because of the placental attachment. So this can be, the placental attachment can be in upper segment and lower segment. But even if the attachment in the lower segment, the scar will doesn't become weak in the case of a lower segment scar. There, if it is in the case of classical scar, the increased chances of placental implantation will be there in the upper segment, and there will be thinning and dehiscence of the scar because of the placental attachment. Okay, the scar rupture rates we have already seen. It is much higher in the 2 to 9% in the classical section. So timing of rupture, it happens mostly in the labor, and it can also it happen before the onset of labor, that is before the term itself, and in the classical it happens in the pregnancy and in the labor. So ideally, according to etiology, we need to plan the pregnancies at 36 to 37 weeks. So, coming to the factors, the other factors which affect the like type of uterine closure. So, lower transverse uterine incision can be sutured either by one layer or two layer. Or if we compare this single layer versus double layer and locking versus non-locking, the uterine dehiscence or rupture rates did not differ. They didn't differ much. So, we don't need to consider about the type of the closure which has happened in the first pregnancies. So, women who have sustained previous uterine rupture was also greatest risk. This is a contraindication. We have already seen this. Next, coming to the inter-delivery interval and inter-pregnancy interval. So, inter-delivery interval of less than 18 months, and inter-pregnancy interval is the time between inter-pregnancy interval is nothing but the time between the woman the time between the woman when she is not pregnant. So, with the starting of the first pregnancy, second pregnancy, and ending of the first pregnancy, the time period is called as interpregnancy. Coming to interdelivery is a time period between the elapse between first delivery and the next delivery. It includes the whole pregnancy also, interdelivery. This interpregnancy is what the time between only when the woman is not pregnant. As soon as she becomes pregnant, before her pregnancy only it is considered. So this is associated with the threefold increased risk of the rupture rates. So, in women who has undergone non-recurrent indications such as any presentations like breech, transverse slice, and placenta previous, all such indications may not be a recurrent, like again in the next pregnancy. So, if the first section has done due to non-recurrent indications, then success of TOLAC is 90%. If the prior section is done because of fetal compromise, then the TOLAC rate is 80%. The prior second stage arrest, cesarean delivery. If the first section has done because of the second stage arrest, then the chances of a second stage uterine rupture will be higher if the woman has undergone further TOLAC. So in breech presentation, we can go for the few studies. There are a few studies which say external cephalic version is safe, and there are few studies which say external cephalic version is not contraindicated. Sorry. So, what are the factors that increase the success of Vbac? As we have seen, the previous vaginal birth will increase, and if the labor is spontaneous onset, if the gestational age is less than 40 at the onset of labor, and the interpregnancy interval of more than 2 years, these are considered as the favorable factors. And what are the factors which decrease the success of Vbac? And if it is an induced labor, if she has no previous vaginal births, if the BMI is more than 30, and if she is GDM, and if her gestational age is more than 41 weeks of gestation, and the baby's estimated weight is more than 4 kgs, and the previous preterm LSCS at the time of the cervical dilatation at the time of admission is less than 4 centimeters, and shorter interpregnancy interval, short stature, advanced maternal age, and if any recurrent indications like CPD, labor dystocia of the initial section, and history of any post-operative infection or resuturing. All these are the factors which decrease the success of the Vbac. Next, coming to the antenatal management in women with the previous LSCS. So, risk assessment for the TOLAC. This should be done at the first antenatal visit itself. What are the factors to be noted? We need to see how many previous sections were done and what was the indication of the prior section. Are the discharge summaries or any notes available with the patient? Does any puerperal complications occurred to the patient? What was the gestational age at the time of the prior surgery? On what is the whether she has undergone any previous SVDs. If yes, she has previous SVDs, whether it is before or whether it is after. It is before or it is after. If it is after uterine surgery, that is considered as VBAC only. So this has more chances of successful VBAC in this pregnancy. And if the interconceptional period is more than 2 years and any associated medical problems, if she is having, all these things should be assessed in the first booking visit itself. The routine measurement of a lower uterine segment thickness on the ultrasound. We can see in the ultrasound reports they mention the scar thickness. Does this have any role in predicting the chances of uterine rupture in this pregnancy? So they say that the routine measurement of the lower uterine segment thickness on USG is not recommended with the in the women with prior cesarean, because we have seen the cases in women with the good scar thickness has also the uterine rupture has happened. Okay, so we cannot predict the chances of the rupture based on the scar thickness. So at the booking visit, we need to counsel regarding the mode of delivery. That should be started ideally at the antenatally. We should not discuss when the patient comes into the labor at that time. We should be prepared, patient and the doctor. Both of them should be prepared for the plan of that is a mode of the delivery. And the woman should be offered information regarding the TOLAC and also LSS, that is elective repeat cesarean delivery, and all the possible risks and benefits and its implication in the future pregnancies. So everything should be explained to the patient. So the how to educate the women. So chances of the successful planned VBAC is a 72 to 76%. The women they will understand much better if we mention the percentages to them. So also inform that this assessment will be an ongoing process. If the woman in this pregnancy lands up into any complications or any obstetric indications, in such cases we can't wait for TOLAC. We should go for the emergency section. So that thing should be explained to the patient properly, and women should be counseled regarding her intended family size and also the risks with the additional sections. If she becomes multi with the previous sections, and then all the risks of injuries and transfusions, all these risks have to be explained to the patient. The counseling is very much plays an important role coming to the VBAC. So we should make a birth plan. Women and also her obstetrician, they should agree upon final decision whether they are going for the section or they are going for the trial. And the mode of the birth, everything should be planned. It should be ideally planned before 36 weeks of gestation. Before 36 weeks, that is we have to keep the plan ready. So a clear birth plan should be documented, which states the boundaries of safe practice to which they have agreed, and all the circumstances under which they may require LSCS should also be explained to the patient in their own understandable language. So coming to the instructions and advice, if the decision is in the favor of TOLAC, then they should also be advised to report early if they have any spontaneous rupture of the membranes, or if they have any increased abdominal pain or any greenish or yellowish discharge kind of thing. They should report early. You need to say all the things during the counseling to the patient, and the consent should be taken from the patient and attenders, and decision is not binding. You can also give her the choice that the decision is not binding, and she has the autonomy to change her mind. If after going home, after thinking on it, she might say that she doesn't want TOLAC and she have to go for elective section, it is her decision. We can't force her to get the TOLAC only because just because she has signed on our consent form or that thing. So antenatal counseling of the woman with a prior section should be documented in the notes. So intrapartum management in women with previous LSCS. So what are the prerequisites of the hospitals which are offering TOLAC? So there should be an immediate access to facilities required for cesarean delivery. As soon as there is an indication arising, we have to be, there should be an access for cesarean delivery, and there should be a continuous FHR monitoring, and there should be an experienced obstetrician who is capable of the monitoring the process of labor and performing emergency LSCS should be available, and the anesthetist and the neonatologist and also should be available, and the cross-matched blood sample should be also be kept ready. So, as we have seen, the success rate is 72 to 76%. At almost 20 to 30% of the women attempting TOLAC may require emergency LSCS. So, all these facilities should be ready, and then only we should offer the TOLAC. So, effective and close monitoring of the labor is essential for the early identification of the impending uterine rupture. A modified photograph to facilitate the documentation of the progress of labor is helpful. See, modified photograph, according to the modified photograph, the latent phase is till 4 centimeters. If we could take a WHO labor care guide, WHO labor guide, then the latent phase is till 5 centimeters. Sorry, latent phase is till 5 centimeters. For TOLAC patients, it is better to go for the usage of modified photograph only, because the most of the uterine ruptures happen at 4 to 5 centimeters of dilatation. So if we use WHO labor care guide, we may miss documentation of some patients. So it's recommended. Just it's our choice, but it's better if we go with the modified photograph. And any maternal tachycardia should be an early indication of the scar dehiscence. Monitoring of the intensity, duration, and the frequency of the uterine contractions should be done. Any forceps and venters can be used to cut short the second stage of labor, but this is not compulsory. This can be used, but it is not always required. It's not like we should use it for sure. And the duration of the labor should be closely monitored. If any prolongation of the labor is noticed, then we should consider it as labor dystocia, or any imminent rupture and or dehiscence should be suspected. So in case of prolonged first stage or the second stage of the labor, better to have a lower threshold to decide for the section, as these can be signs for imminent rupture and or dehiscence. Coming to the uterine ruptures, more than 90% of the ruptures will occur at 4 to 5 centimeters of dilatation, and 18% of ruptures will occur at the second stage of labor, and 8% of ruptures are detected after vaginal delivery. So, the continuous electronic fetal monitoring is very, very important, and this should be recommended. This is recommended from the onset of the uterine contractions till the duration of the TOLAC, and because the abnormal CTG trace, this is the most consistent finding in the women having the uterine rupture. We have seen that approximately 55 to 87% of the rupture cases has an abnormal CTG trace. So what is that abnormality? We'll discuss in the next slides. Epidural analgesia is preferred for the TOLAC, as adequate pain relief will encourage more and more women to choose for the TOLAC, and epidural has no effect on the rates of failed TOLAC or the operative vaginal deliveries. So, effective regional anesthesia will not mask the signs and symptoms of the impending rupture. Okay, as the most consistent sign of rupture is the fetal heart rate abnormalities. But there is they'll say that the frequent epidural dosing can be an independent risk factor again for the impending rupture in TOLAC. So, increasing doses and increasing requirement of pain analgesia should raise the suspicion of the uterine rupture, because this is likely to precede the uterine rupture. How to diagnose early diagnosis of uterine scar rupture? So this will reduce both the maternal and also the fetal mortality and morbidity. So this is very essential thing. There is no single pathognomic feature that is indicative of uterine rupture, but if it is present, then if these are present, then we should be conscious. So what are the things to be checked? Any abnormal CTG if the patient is having severe abdominal pain, and this pain is persistent even in between contractions also, then we should be more suspicious. And any chest pain, any shoulder tip pain, any sudden onset SOB, any acute onset of scar tenderness, abnormal vaginal bleeding, or any hematuria, or cessation of previously efficient uterine activity or maternal tachy, hypotension, shock, any loss of station of the presenting part. These are few features which should be kept in mind and during the process of TOLAC. So coming to the process of delivery, the same techniques are used in VBAC for the delivery of the fetus and the placenta, as in the case of similar to any other vaginal deliveries. The indications, contraindications, prerequisites, procedures for operative vaginal birth are also same as in the case of any other normal vaginal delivery. Induction and augmentation are not contraindicated in women with the previous LSCS. Induction and labor are not contraindicated in women with the induction and labor are not contraindicated in women with a previous cesarean delivery. They are associated with the more risk, 2 to 3 fold increased risk of rupture and 1 to 5 fold increased risk of cesarean delivery. They land up in the chances of they landing up into the elective section are more. So just they are not contraindicated, but they will increase the risk of rupture. So risk of uterine rupture in women who has no previous vaginal birth and who has unfavorable cervix, and women who are on induction. Next, coming to the cervical ripening and labor stimulation. We have seen that the labor induction and augmentation are not contraindicated, but we should use judicious medications. Like labor induction is associated with the higher TOLAC failure rate compared with the spontaneous labor. We have already seen this. So induction and augmentation is ideally avoided in women who has unknown prior incision type. What if that was a classical section? It will end up in the uterine rupture. So better to avoid if the prior incision is of unknown type. And the use of oxytocin for the labor augmentation and induction has been increased the rupture rates. We have seen if we have used oxytocin, the chances of uterine rupture will be more. So what are the percentages? If we go for the transcervical Foley catheter for a labor induction, then it is 1.6%. This is not much higher when compared to the spontaneous labor. It is again 1.1%. When if we do ARM and if we go for ARM, then it is 1.2%. So there is no much difference between the Foley and spontaneous and ARM. So we can go for this transcervical Foley catheterization. The mechanical method of induction, such as a transcervical Foley catheterization, is preferable for method of induction because this is less likely to be associated with the uterine hyperstimulation. Okay, the use of a PGE1, that is misoprostol, is contraindication as this is a much stronger, which causes more contraction. So we ideally avoid misoprost. And PGE2 gel, this can be used, but also used with the caution. So although augmentation is not contraindication, it should be preceded by the careful assessment of by the experienced obstetrician, and the appropriate maternal counseling should be preceded to this augmentation. Oxytocin augmentation should be titrated. It should not exceed, the contractions should not exceed the maximum rate of 4 in 10 minutes. So ideally it should not exceed 4 in 10 minutes. Coming to the uterine scar exploration. Following Vbac, some clinicians routinely document the integrity of the prior scar by placing the hand through the dilated cervix, through the inner surface, through the dilated cervix through the inner surface of the checking the lower uterine segment. Only some clinicians do like this, and but routine exploration is considered to be unnecessary by the others. What guidelines say is transcervical evaluation need to be only performed in women who have severe third stage bleeding, that is severe PPH. If the bleeding is more, then only we should go for this method of transcervical exploration. Otherwise, routinely it is not recommended. And if the tear is noted to be large or any breach into the peritoneal cavity has been noted, then or any presence of active bleeding is noted, then we should go for a laparotomy and repair the tear. TOLAC in special circumstances. In coming to the preterm labor, planned preterm Vbac has a successful rates same like a planned term Vbac. It has lower risk of rupture. Okay. In the case of more than previous LSCS, we have seen two previous LSCS has a risk rupture of point 2 to point, sorry, it is a 0.9 to 1.8. The rupture has increased. So, though few meta-analysis showed no significant difference in the rate of success, VBAC with the two previous LSCS and those with a single previous birth, the risk of rupture is more. So, if we proceeded with a TOLAC, and it should be conducted only in the tertiary care center. In the case of multiple gestation, this does not increase the rate of rupture. If the first twin is cephalic, like similar to any other normal vaginal delivery, we can give the trial of labor. In the coming to the elective repeat section, it should be planned at 39 completed weeks of gestation. So we should not delay. In the case of one previous LSCS, it is better to terminate at 39 completed weeks. Delaying delivery beyond 40 weeks is associated with neonatal morbidity. So we should not avoid. It is better for one previous LSCS to terminate at 39 weeks. If it is two previous LSCS, it is better to terminate at 38 weeks. If it is three previous LSCS, it is better to terminate at 37 weeks. As the number of LSCS increases, the rate of rupture will also increase. So, better we should terminate it 1 week earlier. How to diagnose the uterine scar rupture? We have already seen in early diagnosis, all these signs should be kept in mind. Dull aching suprapubic pain, which is persistence even between the contractions and the bleeding PV and shoulder tip pain, chest pain, bladder tenesmus, sudden onset SOB. All these are the symptoms, and signs include like tachycardia, hypotension, shock, hematuria, scar tenderness, ballooning of the lower uterine segment, abnormal CTG, MSL, and any loss of station are the signs of the uterine rupture. Progress of labor in women attempting TOLAC is same like in the normal women. So there are no specific patterns suggesting of a uterine rupture. So before hypovolemic shock develop also, the symptoms and findings of the patient also appear very confusing. So hemoperitoneum, we should be very, very careful, and minute suspicion also should raise our concern of uterine rupture. Hemoperitoneum from the ruptured uterus may result in the diaphragmatic irritation and cause pain, referring to the chest. So, the reason for the shoulder tip pain and the chest pain is the hemoperitoneum. So, uterine rupture is classified. It can be either complete or incomplete. Complete when all the uterine wall layers are separated, including the visceral peritoneum. If the peritoneum is also separated, then it is called as complete rupture. It is incomplete when the uterine muscles is separated, but the visceral peritoneum is intact. So, incomplete rupture is also known as a uterine dehiscence. This is the image showing the complete uterine rupture. We can see the ballooning of the membranes out from the uterine scar. This is the upper segment. This is the lower segment. We can see the that the uterine, all the uterine walls, including the peritoneum, has been gone. So we can see the bulging membranes directly. The most common sign of the uterine rupture is a non-reassuring fetal heart rate pattern. That is, it has variable decils that will evolve into late decils, and next bradycardia. So here in this image we can see it has a bradycardia. Decils, it is started with the variable decils and it is evolving into the late decils and again into the bradycardia. So here in this CTG we can also see that the uterine tone has suddenly increased, followed by the tone has completely has diminished. If the fetal presenting part has already entered the pelvis, then on doing parvaginal examination, we can see loss of station can be detected. If the fetus is partly or totally extruded from the uterine rupture, then on parabdomen examination, we can see that like we can see the presenting part. And in PV examination, we can see loss of a station. A firm contracted uterus can also be felt along the side of the fetus. So, emergent sonography in the labor room, if an ultrasound machine is there, we can diagnose the uterine rupture by performing an ultrasound. So, ultimately, the diagnosis of the uterine rupture becomes evident because of the fetal distress, and occasionally, mostly, it is because of the fetal distress. Occasionally, it can also be become evident because of the maternal hypovolemia or from the concealed hemorrhage. How to manage? With the rupture and expulsion of the fetus into the peritoneal cavity, the chances with the intact fetal survival are very poor. So, fetal condition depends on the degree to which a placental implantation that remains intact. How much the placenta has been separated. Chance of the intact fetal survival is by the immediate delivery. It should be mostly by the laparotomy. If the rupture is followed by the total placental separation, only very few fetal will be salvaged, and most of them have a neurological deficit, or they may all land up into hypoxic ischemic encephalopathy, and they may also even die. Fetal condition depends upon the placental separation. In case of total placental separation, then the maternal hypovolemia will be more, and the fetal hypoxia and fetal death and fetal demise will be more. If immediate delivery should be done as earliest as so immediate delivery by the laparotomy should be done. This will help in with along with the adequate resuscitation will help to salvage both the mother and the fetus. Following complete rupture during TOLAC, usually hysterectomy is required. In selected cases, suture repair with the uterine preservation can also be performed, will also be enough in selected cases. The prognosis completely depends upon whether it is scar dehiscence or it is scar rupture, whether it is in the upper segment, whether it is in the lower segment. So, lower segment scar dehiscence outcome is good for both the mother and the fetus. In the case of lower segment scar rupture, maternal death is rare, and perinatal mortality is also better, less compared to the upper segment. Rupture in the upper segment is more hazardous, and it is more hazardous, which can occur in the pregnancy or also during the labor. It is more hazardous. This is a table by the ACOG. So education and counseling should be ideally started conceptionally, and we should provide the patients a pamphlet regarding the TOLAC and Vbac and the associated complications and advantages should be explained. So delivery plan should be made, and we should revisit the delivery plan in each trimester, and they can alter the decisions, and also they confirm the facility capabilities. So we should review the document. Previous discharge summaries from the patient should be asked, and the previous operative notes should be checked, and any absolute or relative contraindications should be checked, and we need to reconsider again the risks as the pregnancy progresses. The careful consideration if it is more than one previous section, or it is unknown incision, it should be twins. If it is macrosomia, we should be more meticulous. Coming to during the labor and delivery, we need to again review the previous medical reports and operative notes, and even our notes should be reviewed again. If we are in using, we should be careful, and in the unfavorable cervix and high stations, we need to be careful. We can go for artificial rupture of membranes, better to avoid prostaglandins. PGE2 is absolute contraindication. Is absolute contraindication. PGE2 can be tried, and that is also with the caution. We need to use oxytocin meticulously, and continuous fetal monitoring should be done. Any abnormal labor, if detected, this should arise a suspicion of uterine rupture, and we need to check for the CTGs regularly, and if needed, like if at all any impending signs have been noticed, we should abandon the process of TOLAC and go for the emergency LSCS. We should recommend against home births. This is a table from the Williams, which is comparing ACOG and SOGC, that is Society of Obstetricians and Gynecologists of Canada, and RCOG guidelines. This is a table from RCOG, which is providing us the comparison table between the planned VBAC and the elective repeat cesarean section in the women with the previous one LSCS, which is done at 39 weeks. So success rate is 72 to 75%, and shorter hospital stay. 0.5% of the uterine scar rupture rates are there, and there is a increased likelihood of future vaginal birth. There is a risk of anal sphincter injury in the women with the who are undergoing a VBAC is 5%, and there are chances of instrumental delivery which is on the higher end, that is approximately of 40%. These are to be informed in the case of a VBAC. When coming to the elective repeat cesarean delivery, then the uterine rupture rate is much lesser, and but they have longer recovery, and this will reduce the risk of a pelvic organ prolapse, and but the increased risk of a placenta previa, creta adhesions, and the successive cesarean deliveries and abdominal surgeries are there in the case of elective repeat section. Next, coming to the infant outcomes, transient respiratory morbidity will be there up to 2 to 3% in VBAC, and 4 to 5% in the case of a section. So all these stillbirth rate, hypoxemic ischemic encephalopathy, and perinatal deaths are a bit of higher end in the case of TOLAC compared to the elective repeat section. This is also a VBAC checklist given from the RCOG. So while explaining the patient, we need to say if it is one previous LSCS without any previous vaginal birth, then the success rate is 72 to 75%. After discussing with this patient, we need to tick it. Next, if it is one previous LSCS and at least there is one previous vaginal birth, then then the success rate has been increased 85 to 90%. After discussing this, we need to tick it again. So unsuccessful VBAC is more in the case of induced and no previous deliveries and BMI more than 30, and if it is labor dystocia, if all these factors, the successful VBAC is achieved only in 40% of cases. So all these things should be informed prior hand, as the patient's decision is plays a crucial role in the case of VBAC. And then the uterine rupture rates are higher in the case of VBAC. They are less in elective section, and blood transfusion risk is also almost same, but a bit higher on the VBAC. No significance of endometriosis, and any serious complications are more in like placenta previa and creta are more in the repeat sections. Okay, so mortality overall, if you see, the mortality is more is in the case of elective repeat cesarean deliveries, and fetal only transient respiratory morbidity will be more for elective, and all others will be more for VBAC. These are the differences which have taken the information from. Thank you.